brachial plexus nerve block. The interscalene block is ideal for shoulder pathology like the shoulder dislocation seen here in this X-ray. The distribution of the anesthesia of the interscalene brachial plexus nerve block is shown here. Cutaneous anesthesia over the shoulder and the lateral arm can be achieved. The glenohumeral joint and the humerus are also covered by this block. With higher volumes of anesthetic, you also get anesthesia to the lateral wrist and hand. To identify the brachial plexus at the level of the scalene muscles, place the linear probe transversely on the neck over the carotid artery and the internal jugular vein. You can start about halfway up the neck, slide lateral to identify the anterior and the middle scalene muscles. The brachial plexus lies in the fascial plane between these muscles. Alternatively, you can find the brachial plexus just superior to the clavicle and trace these nerve roots up into the mid-neck as shown here. The carotid artery is seen in the most medial aspect of this ultrasound image, outlined in red here. Moving laterally from this, you can see the muscle of the anterior scalene. Moving even more lateral, you'll find the middle scalene muscle. The fascial plane between these two muscles contains the nerve roots depicted in yellow here. The classic appearance of these nerve roots is seen as a stoplight 1, 2, 3, with the C6, C7, and C8 nerve roots in a vertical row. This video clip shows the scanning technique. The sonographer has the ultrasound probe transversely across the middle neck. The pulsations of the carotid artery define the medial border. Just lateral, you see the anterior scalene muscle here and middle scalene muscle. Looking in the fascial plane between these muscle bodies, you see the hypoechoic cords of the brachial plexus. Once you have identified all the relevant anatomy, you can set up to perform the nerve block procedure. The ideal positioning of the patient is sitting up with the provider standing behind the patient. The ultrasound can be positioned on the opposite side of the patient for the most convenient visualization. The needle is inserted just lateral to the edge of the probe, and using an in-plane technique, this is advanced under direct ultrasound guidance. The needle is advanced from lateral to medial. The needle passes through the middle scalene muscle while aiming the needle tip at the space just lateral to the nerve roots, which are shown in yellow here, with the target being this orange star. Injection of anesthetic should result in anechoic fluid entering the fascial plane between the anterior and the middle scalene muscles and surround the nerve roots. 7 to 10 mLs of anesthetic is needed to achieve a good block. The other two techniques for the brachial plexus nerve block is the supraclavicular and the infraclavicular approach, and we'll discuss these next. The supraclavicular and infraclavicular nerve block produce similar effects of analgesia. They provide an extensive block of the upper extremity. Cutaneous anesthesia is produced over the lateral upper arm as well as the elbow, the entire forearm, wrist, and hand. Bony anesthesia is effective from the distal half of the humerus through the wrist and hand. These two block techniques are useful for a variety of procedures involving the upper extremity. For example, elbow dislocations or arm abscesses, such as the one shown here, that require extensive incision and drainage. Other procedures like burn wound care can be done without procedural sedation when using these blocks. Let's discuss how to perform the supraclavicular brachial plexus nerve block. To identify the brachial plexus in the supraclavicular region, place the probe in the transverse orientation just superior to the clavicle, sliding the probe lateral until you see the noticeable landmark of the subclavian artery in this short axis. Once the subclavian artery is identified in the short axis, shown here in red, the other important structures can be identified. A hyperechoic line just deep to the artery is the first rib. The pleural interface may also be seen deep to the rib, as shown in gray here and here. The cords of the brachial plexus are lateral to the artery, and these can be seen as hypoechoic circular structures. They are highlighted here in yellow. This clip shows the relevant anatomy. The pulsating subclavian artery seen here lies medial to the cords of the brachial plexus, shown here. The shadow of the first rib is shown here. This serves as a nice backstop during the procedure, and if placed in this orientation, can prevent the needle tip from entering the pleural space. This technique is easiest to perform if you are standing behind the patient with the ultrasound machine opposite to you. The needle is inserted just lateral to the edge of the probe and advanced from lateral to medial using the in-plane technique. The needle is advanced, aiming the needle tip toward the space just superficial to the first rib, which is outlined in white here. Since the cords of the brachial plexus may be spread out in this area, you may need to redirect the needle and make multiple injections to surround the plexus with anesthetic. A total of 10 to 15 mLs of anesthetic is needed to achieve a good block using the supraclavicular approach. The last technique that we will discuss is the infraclavicular approach to the brachial plexus nerve block. To visualize the anatomy and the landmarks needed to perform the infraclavicular brachial plexus nerve block, the ultrasound probe is placed perpendicular to the clavicle, and scanning medial to lateral, you are attempting to identify the axillary artery in its short axis. In this still ultrasound image, we're able to see all the landmarks needed to perform this block. Towards the head, we see the bright border and shadowing of the clavicle. The axillary artery is seen here in its short axis, highlighted in red. The medial, lateral, and posterior cords of the brachial plexus are outlined in yellow here. The axillary vein, shown in blue here, is just caudal to the artery. You may also see the outline of the pleura deep to these structures, and this is an important border to recognize. In this clip, you see the scanning technique to identify the landmarks in this area. Again, we see the border of the clavicle here, which defines the cephalad landmark. You see the pulsation of the axillary artery here. And as we scan through, we see the cords of the brachial plexus, and deep to this we see the border of the pleura. Once all the relevant anatomy is identified, you can set up to perform the procedure. The approach of the needle is just superior to the edge of the ultrasound probe. The needle is inserted in between the inferior border of the clavicle and the ultrasound probe, and this is advanced using a in-plane approach toward the target nerve. This animation shows the ideal trajectory of the needle, sliding just inferior to the border of the clavicle. The target for your needle tip is just deep and caudate to the axillary artery, which is shown as a star here. If the needle tip is placed here, it should be within the axillary sheath, and injection of anesthetic should fill around the axillary artery and surround the 3 cords. 15 to 20 mLs of anesthetic is needed to achieve a good block using the infraclavicular approach. Thank you very much for your attention and for your interest in these nerve block procedures that can greatly benefit our patients.